Ladies and gentlemen, a warm evening to you all. Today I'm going to talk about the biomarkers in heart failure. I'll just put you through some questions as well as my practice is. Please don't mind, there are so many of my seniors here, but please don't mind my questions. Okay, these are what are the things that we are going to learn in the next 10 minutes. Really, seriously, yes. What are the new cutoffs for the biomarkers? Like we all know that BNP is elevated in heart failure. Nobody is disputing that. But what are the cutoffs? Where should we see? Now, at night, there are calls from my MICU saying that, sir, this patient has a NT-proBNP of 300, and what should I do? Like, my goodness, the cutoffs that they give in some of the reports are for BNP, not for NT-proBNP. You have to educate your people in MICU, otherwise, to the new cutoffs, otherwise they'll keep on disturbing you at night. Which are the biomarkers to use? NT-proBNP, NT-proBNP, which is better, or any other markers if you are planning to use, any new markers are there. How to monitor the treatment with biomarkers, whether to use these markers will help or not. This is a very important thing. Yeah, we have a new gadget. We have an iPhone 10. Is it better than the iPhone 7 that you are already owning or not? That's what you have to see. You have got a new biomarker. I have to make sure that there are clinically ascertainable benefits with these new markers if you are going to use them, if you are going to charge the patient to these. And then what are the potential uses for these biomarkers, and then is it enough to decrease these biomarkers, or is there a way to decrease these biomarkers with which we can improve the survival, and what should we do if the maximum medical therapy cannot bring back the biomarkers to normal level, and what are the caveats in using these biomarkers? I'll tell you a small case study which is relevant. A 65-year-old obese Mrs. SR has presented to the OP with class 4 breathlessness following an URI. She was suspected to have a flash pulmonary edema. She also has history of COPD, and a biomarker was measured, and then her BNP at admission was 600 picograms per ml. Does she have a heart failure or not? Now, what are the things that we should consider here? Now, the ER people have called you and told that the NT-proBNP is 600. Now, what are your impressions? Like, shall she have failure or not? The following will be my thought process. Okay, 600 NT-proBNP is elevated, yes, but age-related cutoff you have to take, and then if the age-related cutoff indicates that less than 50 years of age, 50 to 75 years of age, and more than 75 years of age, you have to consider. Less than 50 years of the age, you should take it as 450 picograms per ml, and 50 to 75 years of age, the cutoff that you should be taking is 900 picograms per ml, and then above the 75 years, you have to take it as 1800 picograms per ml as the cutoff. I'll come to the cutoffs again, and then the other things are, I told you she is obese. Once I tell you that she is obese, you should always think that the proBNPs are lower in obese people. ProBNPs are lower in obeses. That means that even if she has a failure, the proBNPs are not going to be elevated as much as a lean person. And so, lot of patients you see, they come for a fitness for bariatric surgery, they'll be having symptoms of congestive heart failure. You do an NT-proBNP, you'll think that the NT-proBNP is normal, whereas after the surgery is done, they land up in failure and the NT-proBNP will be alarmingly high. So you have to be careful with obese people. That is one thing that is important. And the other thing is flash pulmonary edema, usually the NT-proBNP doesn't elevate like that, because we have to understand the mechanism. We have to understand this. NT-proBNP or BNP will elevate according to the end-diastolic volume and pressure. So the flash pulmonary edema doesn't give the time for these markers to increase in the blood. So the NT-proBNP may not be elevated. So all said and done, considering this 600 picograms per ml is abnormal, despite the fact that the age cutoff is less than 450 nanograms. These are the cutoffs for BNPs. This is important. There are rule-in cutoffs and rule-out cutoffs. Okay, there are two things in BNP when you are talking about. Rule-out cutoff is you get a value of NT-proBNP or BNP with which you can say that this patient is definitely not having a congestive heart failure. That is a rule-out cutoff. And what is a rule-in cutoff? You have this much of BNP, you can definitely say this is a congestive heart failure, be it left or right. So the rule-out cutoffs are BNP of less than 100 picograms per ml, and for NT-proBNP, the age-related cutoffs. And then The rule in cutoff is for BNP of more than 400, then the patient is definitely having congestive heart failure, and NT-proBNP, again the age-related cutoffs. So these are the important things. When you rule in, when you rule out. There is a gray area in between. BNP levels between 100 and 400, it can go either way. So you have to call the third umpire at that time. Take the other things, lung ultrasound, do the echo, see the E by E prime ratio, like that. Okay, BNP value can guide the diagnosis in patients with breathlessness, even complex situations. Seriously, I am asking you one question, which among the four statements is incorrect? Biomarkers correlate strongly with diagnosis of heart failure, yes or no? Yes. Biomarkers correlate strongly with prognosis of heart failure, yes or no? Yes again. Biomarker measurement is a must in guiding treatment, yes or no? No. Pre-discharge biomarkers are best for the predicting the prognosis. This is again yes. Now, if you have a baseline BNP, if you have a follow-up BNP, and if you have a pre-discharge BNP, the pre-discharge BNP is the best in predicting the prognosis. The third statement I have told, the measuring is a must in guiding treatment. No, by no means. The guided study has come recently, and then which is clearly showing that NT-proBNP or proBNP guided treatment is not better than the regular optimal medical care as far as the chronic heart failure treatment is concerned in the OPD. So that is important. Okay. A discharge level of less than 125 picograms of BNP or less than 1000 of NT-proBNP should be done. Like BNP, I'll just skip through the trials. I promised Ramesh that I'll give him 2 minutes of time. Which trials have shown the message? Okay. Does the increase in nitrouritic peptide has prognostic value? Very importantly, yes. For every 100 picograms increase in BNP level, there is a 30% increase in the relative risk of death of a patient. So if you see a very high BNP value, you better prognose the patient properly. Okay, and are the NPs only the markers of heart failure? There are so many other things, but some of the important things I'll tell you that is coming up. So the soluble form of suppression factor of tumorigenesis, that is SST3. That is very important in the which is coming up. And then the galactin is there, troponins are important, matrix metalloproteinases are important, TAMPs are important. Okay, many new things are coming, but the first important thing is SSL2. You remember this is going to come up. Even on BNPs, it has shown increased prognostic information. So this is something you have to know. So what about the BNP in general population? If you see the BNP levels in a general population, if they are higher, and then initially if your BNP is normal, and then if it is more than 25% down the line, 2 to 3 years of the time, then your risk of having a congestive heart failure is going to be high, and you are advised to exercise vigorously if you have to prevent that. So that is very important. The serial levels of BNP and the baseline level P in general population is also important, and detectable levels of troponin is also important. Whenever you say, sir, whenever you say. Valvular heart disease and biomarkers, even in MR also this BNP can elevate. And then BNPs are proven to increase the compliance of not only the doctors as well as the patients. And then the using BNP will indicate that, diuretics will bring down the BNPs, and ACE inhibitors, ARBs will bring down the BNPs. And what about ARNI? If you have to bring down the BNP, you bring it down with ACE inhibitors and beta blockers rather than diuretics, because diuretics won't help in prolonging survival. ACE inhibitors and beta blockers do. Whereas in angiotensin receptor blockers with neprilysin inhibitors, there is a small thing. NT-proBNP is not metabolized by the neprilysin inhibitor, whereas BNP is metabolized by the neprilysin inhibitor. So NT-proBNP levels are more or less the same thing, which behave the same way as the rest of the heart failure patients in patients treated with ARNI, whereas BNP doesn't behave so. So you have to be careful. You choose NT-proBNP if you want to monitor a patient on ARNI. That is very important. And then the caveats, I've already told some, obese, and then patients with renal failure and sepsis are going to have increased BNPs, and don't blindly follow any BNP levels. And finally, the important thing is, it is important to bring down the BNP with guideline approved medication rather than just to decrease it. Thank you so very much, ladies and gentlemen. Thank you very much.